John Candelopoulos here at the Laser Vision Arbitrary Surgery Center. We're going to see a nice trick for very advanced keratoconus that theoretically does not have thickness to do any laser manipulation. We can see that the thinnest here is clocked in at 329 microns with the OptiView Avanti angio device. We can see, of course, the robust epithelial remodeling, and we want to perform here Athens protocol CXL. So if we look at the Pentacam maps, let's go and look at the Pentacam maps on that same patient. We can see that the keratometry goes all the way up to the 60s, 60.7, 60.9. We can also see the almost central cone. Posterior elevation confirms the concavity of the cornea. Anterior elevation confirms the cone. So in essence, we don't have the numbers here to treat with the Athens protocol because our topography guided treatment will have no room to treat. And these are the numbers here, but we have described and we've published this. We can do the following trick. Of course, always in discussion and agreement with the patient. We know that this patient's refraction is close to -10, -4 at 40. So even if we did perform the Athens protocol, combined topography guided PRK and CXL, she would end up rather myopic anyway. So in lieu of being able to reshape the cornea, we're going to arbitrarily, and we're treating here with the Alcon EX500 contoura platform. Of course, we cannot do this in the US. We can do this outside the US. We're going to treat arbitrarily with a hyperopic treatment. We'll go to +1.5. See what happens at the area on the cone that the software wants to treat. It becomes much smoother. There's still a treatment here. So I'm going to add a +2. So I'm going to a +2, treating hyperopic treatment. It's almost gone. I'm going to go a little bit more. +2 and change. So it's almost gone. So we can see here that by manipulating arbitrarily a hyperopic contoura treatment, I'm taking away the removal of tissue that costs the most in this very thin cornea. I'm removing almost no tissue from that area. The benefit here is that I'm normalizing the cornea the maximum enough. Of course, in the US, we cannot do a 5.5 optical zone. The minimal will be a 6 optical zone. Same thing in the US, we cannot do hyperopia. So we've published on this in the US. What we would have done is we would have treated, if we were in the US, we would have treated on an optical zone of 6. This is the minimal available in the US. We would not be able to treat a +2.5. So we would treat directly on the epithelium the 0, plus arbitrarily a -2.5 to remove the epithelium centrally. So we would treat this treatment, -2.5 at 36 degrees on the epithelium, and then use a separate card to treat the +2.5 we designed before, in addition to a +2.5 to account for peripheral epithelial removal. So in total, a +5. So we would have treated in the US on a separate card, a +5, and then this contour treatment at 6mm optical zone, and this would account the +2.5, the -2.5 for the epithelial removal, and the rest for the treatment we're going to actually do here in Athens, Greece. I'm going back to our numbers. They were optical zone 5.5. We said we're going to treat it +2.5 to sidestep treatment at this very sensitive area of the cone, which is already very thin. So I'm taking away the treatment from that area, and I'm treating hyperopically, and I expect this eye to turn a little bit more myopic. And I know I can address that with a soft contact lens or with an ICL at a second time, of course in agreement with the patient. Always the rule with us is increase the transition zone to the maximum possible, which is 175 here, because as you saw, this makes the hyperopic arc broader and reduces the scarring potential of the procedure. So these are the tricks, the pearls of how to work off-label with your EX500 excimer laser, the Contoura software, whether you're in the US or outside the US, and be able to address this advanced keratoconus in a patient who direly needs not just stabilization of the keratoconus, but also visual recovery, because the other option here would be keratoplasty technique, whether that be penetrating keratoplasty or the new tissue enhancing procedures, KIRS or CTAC. John Kanellopoulos from a center here in Athens, Greece. Thanks so much for watching.